hypertrophic cardiomyopathy versus hypertension.
Thank you, sir. Thank you, Tahmina. My today's topic is hypertrophic cardiomyopathy versus hypertension. I'm Dr. Shahana Zaman, Assistant Professor Cardiology in ICVT, going to present. First of all, what is hypertrophic cardiomyopathy? It is the presence of left ventricular hypertrophy of a non-dilated left ventricle in absence of another cardiac or systemic disease, which could explain the degree of left ventricular hypertrophy. Most common inherited disorder among cardiovascular diseases. Its prevalence is about it is autosomal dominant inheritance with variable penetration and expression. It is the leading cause of death in young athletes. It often predisposes to life-threatening arrhythmias. Special echo features of ACM is hypertrophy of one segment of LV, which is more than 15 millimeter at end. It typically in ACM is asymmetric with frequent involvement of septum and anterior, but can involve anterior lateral wall sparing septum and rarely the posterior wall. After uniform hypertrophy of entire LV, which is known as concentric left ventricular hypertrophy, or may be localized to the left ventricular apex, which is called apical hypertrophic cardiomyopathy. May also occur, and patient may present with atrial flow obstruction. When hypertrophy involves entire LV, the magnitude vary from one segment to another. Hypertrophy is almost always severe, which is about 20 to 25 millimeter, and even massive, more than 30 millimeter. And now, in ACM, it can be asymmetric septal hypertrophy, concentric, apical, or mean ventricular hypertrophy. With the of hypertrophy, hypertrophic cardiomyopathy can be classified into obstructive and non-obstructive. Obstruction can be occur in LVOT, mid-cavitary, and apical. And non-obstructive cardiomyopathy may be as asymmetrical septal hypertrophy or concentric hypertrophy. And how do we approach a patient with a hypertrophic cardiomyopathy? The first, high index of suspicion is necessary. Then history, clinical examination, our investigation tools are ECG, echocardiography, and cardiac MRI. Regarding ECG, abnormal in 90% of symptomatic patients and about 75% of asymptomatic relatives. Most common abnormalities include left ventricular hypertrophy, STT change, left atrial enlargement, deep and narrow Q waves in inferior and lateral leads, and diminished R waves in the lateral precordial leads and arrhythmias. Then what are the role of echocardiography in ACM? It is very important role in regarding diagnosis and prognosis, defining pathophysiology, quantifying hemodynamic severity, management strategy, serial monitoring, and screening of first-degree relative athletes. Now, what are the findings of we found in echocardiography? These are, first of one, left ventricular hypertrophy in absence of other causes. Small LV cavity, systolic anterior motion of anteromitral leaflet, LVOT narrowing and obstruction, mitral regurgitation, diastolic abnormalities, and normal LV function. Then what are the role of cardiac MRI? Cardiovascular magnetic resonance imaging will also be helpful in many patients, especially when is there any diagnostic uncertainty, poor echocardiographic imaging windows, or uncertainty persists regarding the treatment. Now, this is a case or a story of a young patient who is about 35 years old, come with the typical symptom of chest pain and respiratory distress on exertion with repeated syncope. Echocardiographic reveal asymmetrical septal hypertrophy and narrowing of the LVOT, and floor acceleration was noted in the LVOT. There was asymmetrical septal hypertrophy. Septum is about 21 millimeter and posterior wall is 12 millimeter. SAM was present, and here in the apical fourth chamber view, SAM is nicely appreciated, and gradient was at rest. LVOT gradient was at rest, was 117 millimeter mercury. This is the history of another person, older person who is came to our as an indoor patient 2 weeks ago. He was about 67 years, non-hypertensive, non-diabetic, come with the severe respiratory distress with generalized edema. Echocardiography findings showed asymmetrical septal hypertrophy, but there was no obstruction. He has also pleural effusion. And ECG shows atrial fibrillation, but he had normal ventricular systolic function, but he has diastolic dysfunction. This patient was referred from National Institute of Neurology and Science, and is a Middle-aged lady who's presented there for repeated syncope. And she was advised for echocardiography, and we found this patient at our outdoor echo lab. And echo revealed she had concentric left ventricular hypertrophy, LVOT, there was no LVOT obstruction, but when we meticulously find a search, we found mid-ventricular obstruction. And mid-ventricular obstruction was at rest about 102 millimeter mercury. She had normal left ventricular systolic function, but diastolic, get to diastolic dysfunction with increased LV-EDP. This is the classical pattern of mid-ventricular obstruction, and this is the dagger-shaped shaped gradient, which is it is a patient, another patient. A patient of 45 years came to us with the history of palpitation. His ECG showed widespread deep T wave inversion. Then his precordial examination was normal, and echo shows apical hypertrophy. And apical hypertrophy, at another name is Yamaguchi, and Yamaguchi type apical hypertrophy is very common in case of Japanese people. This is another patient who is advised for cataract surgery, but echo shows ECG shows STT changes and advised for echocardiography. And he was non-hypertensive, non-diabetic, and echo shows concentric left ventricular hypertrophy. And we categorize this patient as the concentric hypertrophic cardiomyopathy. He has normal left ventricular systolic function and diastolic function. Now, left ventricular hypertrophy in hypertension. In hypertension, left ventricular hypertrophy occurs due to heart's adaptive response to a chronically increased workload. Left ventricular hypertrophy prevalence varies with severity of hypertension. It's ranging from less than 20% in mild hypertension to almost 100% in severe or complicated hypertension. ECG findings in hypertension is same as in the hypertrophic cardiomyopathy, like left ventricular hypertrophy, LAD, STT change, LA enlargement, and arrhythmias. Echocardiographic findings, assessment of hypertensions are LV hypertrophy, LV systolic function normal, diastolic abnormality, and increased pulmonary hypertension. This patient came to in echo outdoor lab with a history of dyspnea on exertion, and echo revealed concentric type hypertrophy. His blood pressure was on admission about 180 by 100 millimeter mercury. He was his systolic function was normal, but diastolic function was impaired, and he was advised antihypertensive therapy. And what's the diagnostic challenge? Diagnostic challenge arises when an elderly person has marked LV hypertrophy with hypertension. This patient has both hypertension and LV hypertrophy is markedly increased, which is about 16 millimeter in both septum and posterior wall. And we diagnose this patient as overlapping hypertension and a hypertrophic cardiomyopathy. 3 months treatment with antihypertensive drugs sufficient to reverse left ventricular hypertrophy. LVS in patient with hypertrophic cardiomyopathy is caused by mutation in sarcomere genes and not reversible. In the other hand, LVS in hypertensive patient is secondary to increased afterload and may regress during antihypertensive treatment. Angiotensin receptor blocker is the drug of choice. And now, hypertrophic cardiomyopathy versus hypertension. What are the favorable criteria that we conclude it is hypertrophic cardiomyopathy but not hypertension? The favorable things in case of hypertrophic cardiomyopathy is increased IVS thickness, which is about more than 15 millimeter. LV dimension is decreased, but diastolic dysfunction is found both HCM and hypertension patient. Asymmetrical septal hypertrophy is more common in case of hypertrophic cardiomyopathy. LVOT gradient, systolic anterior motion, family history, and RV involvement was noted in case of HCM, and cardiac MRI shows late gadolinium enhancement in case of HCM. My take-home message: since hypertrophic cardiomyopathy is a genetic disease, all first-degree relatives of HCM patients should be screened by echocardiography. Clinical features, disease progression, treatment, and prognosis depends upon types of hypertrophic cardiomyopathy, and echo is essential tool for this purpose. Hypertrophy in hypertension is mild and reversible with proper antihypertensives. A minority of hypertensive patients fall into the morphological gray zone between secondary left ventricular hypertrophy and hypertrophic cardiomyopathy. Regression of LVS after antihypertensive treatment reveals hypertension as the underlying cause of left ventricular hypertrophy, excluding hypertrophic cardiomyopathy. Thank you for giving me attention. সবাইকে বিজয় দিবসের শুভেচ্ছা।